Can you hear me? Can you hear me? Can you hear me?
Yes, doctor.
Okay. You see why I don't like the Zoom? You see, in Microsoft Teams, this does not happen. You can have the whole session without being interrupted every 40 minutes. Huh? And of course, every time I lose some audience, and here in Zoom, I cannot take attendance as well. But with Microsoft Teams, it tells me who attended how long. Okay, so this is another advantage. And the third advantage, of course, is that Microsoft Teams stores the video recording in OneDrive, but here it's stored on the cloud and I have to upload it myself and I have problems uploading files, you see? So this is why it's problematic. So now we are left with 12 students. You want me to continue? Can you still see my slides? No, I need to share again.
No, slides.
I need to
Slides
share again. Okay, can you see my slides now?
It's starting.
Okay.
Oh, yes.
Type small. Now, is it slideshow?
Yes.
Okay.
Yeah.
Okay, so I told you that the baby with congenital hypothyroidism has a pot belly, كرشدة, with a persistent umbilical hernia, all right, and a weak, hoarse, deep-voiced cry. And of course, the mother will notice if she had children before that her child is severely constipated. Normally, all normal babies, they pass usually a stool motion after every feed, whether it is a breastfeed or bottle feed. But in congenital hypothyroidism, there is severe constipation and the baby has constipation. Okay? So this concludes hypothyroidism. Would you like to continue or are you tired? We still need to discuss hyperthyroidism and thyroid nodules for this session. And the other session, the second session, will be equally busy because I need to revise hypo and hyperparathyroidism and adrenal diseases, Cushing, pheochromocytoma, Cons, and Addison's disease. So it's going to be a busy lecture as well. Any suggestions? Tell me. I don't hear any suggestions.
معلش دكتور تاني كان ايه؟
And we have still, I need to discuss with you hyperthyroidism and thyroid nodules, okay, with the imaging, of course, today. And next time, inshallah, it's going to be a very busy session as well because I will revise parathyroid diseases, hyperpara and hypoparathyroidism. And I will revise adrenal diseases, adrenal cortical diseases, Cushing syndrome, pheochromocytoma, Cushing syndrome, Cons disease, and pheochromocytoma, and then glucocorticoid deficiency as well. So it's going to be a very busy session if you decide to postpone today's topics, remaining topics to next time. The alternative would be to hold a third revision session, if you like.
I don't mind continuing. Well, I don't mind the third session.
Type. What about the rest of you? Only one is talking. I cannot see who is talking actually.
I think a third session will be better.
Who is talking? Type. I cannot see who is talking.
Yes, Minna.
Melna. Type.
أنا نجوى.
Type. Dr. Menna and Dr. Nagwa think it would be better to postpone to next time because all of us are tired, including myself. I had a very long day today. I'm sure all of you also had a long day. So, would you like me to continue next week, or shall we continue hyperthyroidism quickly and stop at thyroid nodules?
طيب اوكي ممكن نكمل I don't mind the hyperthyroidism part.
What about the rest of you? I don't hear in the other voices. How many students are there now? Let me check.
We can continue hyperthyroid, doctor.
Okay, Dr. Ed, right?
It's okay for hyperthyroidism, doctor.
Okay. Can you still see my slides? Can you
Yes,
still?
but not on
Yes, doctor.
slideshow.
They're not
They're not
slide.
on slideshow.
Now they are slideshow, right?
Yes.
All right. Okay. So the clinical features of hyperthyroidism, as you all know, the symptoms or the patient's complaints include weight loss in spite of increased appetite. Both of them have to be to go together, all right? Because a patient who has anorexia or loss of appetite, of course, would lose weight. It makes sense. But if a patient eats a lot and in spite of that, she has weight loss, this is significant, okay? Change of behavior, particularly irritability and excessive nervousness. Patient tells you, I keep quarreling with the neighbors, I keep shouting at my husband, at my kids. I wasn't like that before. Okay. Restlessness, particularly in children. They cannot sit still. And this is very irritating for their colleagues and for the teachers at school. So they become punished for being restless all the time, right? Again, malaise, like in hypothyroidism, okay? Stiffness, but this is not a very common symptom. Muscle weakness, again, weakness of the shoulder and pelvic girdle muscles, like in hypothyroidism and like in acromegaly and like in Cushing, all right? Tremors, fine tremors. Choreoathetosis. These are involuntary movements, like tremors, but they are, what is chorea and what is athetosis? Who can tell me?
Korea jerky movements, random,
Yes,
not
irregular.
unpredictable.
Yes, irregular in time and irregular in place. We cannot predict when and where a choreic movement is going to affect the patient. Okay, great. What about athetosis? What is athetosis?
I can't remember.
Athetosis is another involuntary movement, but it involves twisting movement, either of a limb or of the trunk. Okay, so when both of them are combined together, it is called choreoathetosis. These are not actually common symptoms in hyperthyroidism. What is more common is tremors, but it's written in textbooks, so this is why I'm telling you about it. Okay, breathlessness, palpitations. Why do palpitations occur in hyperthyroidism? By the way, palpitations can also occur in hypothyroidism. So tell me why. In other words, what is the mechanism of production of palpitations? Who can tell me?
Palpitation occurs due to increased heart rate, variation of heart rate or rhythm.
Yes. So change in heart rate, either
yes.
tachy, like in hyperthyroidism,
Yes,
or
or
brady, cardia,
Yeah.
like in hypothyroidism. Very good. Arrhythmia, like in hyperthyroidism, particularly in elderly patients with hyperthyroidism, they tend to present with atrial fibrillation or other arrhythmias. But then there is something important that tends to be missed as well. The force of cardiac contraction, the variability of force of the cardiac contraction. In hyperthyroidism, the force of cardiac contraction is increased, right? In hypothyroidism, the force of cardiac contraction may be decreased. So all this can cause palpitations, okay? Heat intolerance, again, in plain wintertime, we have seen many hyperthyroid patients, particularly male patients, wearing a very thin cotton shirt with no undershirt underneath, and they are soaked in their sweat and they feel very hot. They want to open all the windows and the fans. And the other patients who are feeling, the normal patients who are not hyperthyroid, they are feeling very cold and they're quarreling with this hyperthyroid patient because he wants to open the windows and the fans and they want them closed because they feel very cold. All right, always remember heat intolerance. Itching or pruritus is very common, or not common, but a very important symptom in hyperthyroidism. And the cause of it is commonly missed, right? Excessive thirst, of course, because of excessive sweating, vomiting, diarrhea. It may be diarrhea, but the more common is hyperdefecation. Who can tell me the difference between diarrhea and hyperdefecation?
الستول consistency بيبقى normal.
أيوة. In hyperdefecation, there is increased number of motions per day compared to the normal of the patient, but the consistency of the stools is well formed, like normal. But in diarrhea, the consistency tends to be liquid. Okay? And of course, the eye complaints, all of them are found only in Graves' disease. This is why I have marked them with an asterisk. And goiter, of course, goiter is present, and I will show you in several pictures the different kinds of goiter, whether diffuse or multinodular or a single nodule, all right, depending on the cause of hyperthyroidism. In women, there will be oligomenorrhea, okay? In men, there will be loss of libido again and gynecomastia. Why? In hypothyroidism, the problem was hyperprolactinemia. But why does libido occur in hyperthyroidism? Huh? Huh? Who can tell me?
الهايبربرولاكتينيميا
No.
بتحصل في الهايبرثايروديزم.
No. It occurs in hypothyroidism. But what occurs in hyperthyroidism? There is hyperestrogenemia, okay? Hyperestrogenemia. And here, this is what causes the loss of libido and gynecomastia. In men, by definition, gynecomastia means enlargement of the breast in a male, because women, after the age of puberty, normally they have breasts, okay? So like you cannot say a man is hirsute, you cannot say a woman has gynecomastia. Is it clear? Right.
Yes, doctor.
Okay. Onycholysis. I will show you in a minute what onycholysis looks like. It can be a symptom in ladies, particularly those who take particular care of their nails, manicure and pedicure and so on. They come tell you, such ladies, they come, look at my fingernails. You will appreciate that there is something very wrong with the fingernails, but listen to what the patient has to tell you. What is wrong with your fingernails? She will tell you, I cannot keep my fingernails clean. Why is that? I will show you in a minute. You see, this is the hand of a patient trying to make a fist. This is the thumb. Can you see my cursor? This is the thumb, this is the index finger, this is the middle finger, this is the ring finger, and this is the little finger, okay? The pink area of the nail is the area where the nail is overlying the nail bed. The white area or the yellowish area is the area of the nail that grows and that we cut, okay? Now look at the pink line, this in between the pink and the white area. Here it is even, right? Regular. But look at it in the index, ring, middle, and little fingers. It is irregular, and it extends to the middle of the nail almost, here to 2/3 of the nail. Why is that? Because actually the nail grows away from the nail bed, leaving space for dirt to come inside. This is why the lady cannot keep her fingernails clean. So this is onycholysis as a symptom, complaint, but it can be a sign. I mentioned earlier that males, they usually don't take care of, they don't take particular notice of such things. But when you examine the nails of a male patient with Graves' disease, you will find, you may find onycholysis, because not all symptoms and signs that I'm telling you about can be heard of or seen in patients with hyperthyroidism. Okay? Now, children may be excessively tall. Remember, hypothyroidism causes short stature, while hyperthyroidism increases the growth velocity of a child, or it can even lead to tall stature. So before diagnosing a child as having gigantism, please check the thyroid functions. Of course, excessive sweating. And this is you see, onycholysis is so extreme here that you can put a wooden rod between the nail and the nail bed. This is a normal nail. Of course, it can affect all fingernails, like in this picture, except the thumb, but it can also only affect one fingernail. Okay? Now, coming to the signs, those that you detect while examining the patient. Tremors. Of course, tremors, they can be seen in the outstretched hands, like I'm going to show you in the video, and in the protruded tongue. Okay? In children, you will notice hyperkinesis. Hyperkinesis means excessive movement, the total reverse of poverty of movement that we have seen in hypothyroidism. Among the signs, again, in hyperthyroidism, you can find psychosis, like in hypothyroidism. So, hypo and hyperthyroidism can, both of them, lead to psychosis, right? Tachycardia or atrial fibrillation, like I have mentioned, a full bounding pulse, okay? Which means there is a wide pulse pressure. Warm vasodilated peripheries, all right? Due to hyperestrogenemia again, and systolic hypertension. Remember when I told you in hypothyroidism, we found diastolic hypertension. So the diastolic blood pressure is mainly the one that is elevated, but the systolic may be elevated as well. But here in hyperthyroidism, there tends to be systolic hypertension while the diastolic blood pressure is low. Who can tell me why?
الفورس اوف كونتراكشن بتاعت الهارت بتبقى عالية فبتزود السيستوليك وفي
Yes.
peripheral vasodilatation فبيقلل الدايستوليك blood
Yes,
pressure
excellent.
يعني
So the force of cardiac contraction is increased, leading to increased cardiac output, leading to increased systolic blood pressure, while there is vasodilatation, peripheral vasodilatation, reducing this peripheral systemic resistance, leading to low diastolic blood pressure. And this is what causes the wide pulse pressure or the full bounding pulse, right? Excellent. The patient may present with heart failure to the extent that it is said that sorry
دكتور ممكن تاني
yes sorry
ممكن تاني الجزء بتاع الباوندينج pulse
yes bounding pulse means a pulse with a wide pulse pressure يعني a big difference between the systolic and the diastolic blood pressure. Why? Because the systolic blood pressure is high because the cardiac output is increased due to increased force of cardiac contraction with increased stroke volume, right? While the diastolic blood pressure is low because there is peripheral vasodilatation leading to reduced peripheral arterial resistance and a decreased diastolic blood pressure. All right? Is it clear?
okay thank you yes.
You're welcome. All right. Okay, so it is said that in any patient who, particularly if elderly, who comes presenting with heart failure of unknown cause or atrial fibrillation, you have to exclude hyperthyroidism before diagnosing them as having lone atrial fibrillation or cardiomyopathy, right? Now, exophthalmos and ophthalmoplegia, the conjunctival edema, the lid lag, and the periorbital edema, all these are seen only in Graves' disease, okay? And usually there tends to be a goiter in cases of hyperthyroidism. The bruit, this is a French word meaning noise, is exclusively heard over thyroid glands of Graves' disease patients only, not in the other causes of hyperthyroidism. Okay, and of course, if you know the patient from before, or if you are the treating physician, you will notice weight loss. Okay. Of course, if you examine, I mentioned, even if the patient doesn't tell you that he or she they have muscle weakness, you need to examine the muscle power of the shoulder and pelvic girdle muscles, the flexors, the extensors, the abductors, and the adductors of the shoulder and hip joint muscles, right? You may also notice proximal muscle wasting, and onycholysis again. Here, it is considered a sign, not a symptom. And you can see palmar erythema, of course, because of peripheral vasodilatation. I will show you how it looks like in a minute. And in Graves' disease, you may notice Graves' dermopathy, thyroid acropathy, and pretibial myxedema. I will show you in a minute how they look like. So this is palmar erythema. You notice, open your palms and compare to the picture. You see here there is thinner and hypothinner redness, excessive redness, with redness over the heads of the metacarpal bones, while the center of the palm is pale. Okay, this is not like our palms, right? So what are the other causes of palmar erythema? Is it exclusively found in hyperthyroidism, or are there other causes of palmar erythema?
Liver failure.
Yes, liver cell failure. Very good. What else? Another failure. Chronic respiratory failure with CO2 retention can cause also palmar erythema. Okay? Don't forget. And also physiologic. It can be physiologic, like in patients with pregnancy and patients who are taking oral contraceptive pills due to excessive hyperestrogenemia. Okay? Very good.
Yes.
Okay, this is Graves' dermopathy. See, as if there is pitting over the shin of the tibia. But if you try to elicit pitting, you will find it is hard. It doesn't pit. But there is also, it's purple red in color. It's not tender, and it looks like peau d'orange, like the peel of an orange, right? You can also find it on the dorsum of the feet. Okay. Another term for it is pretibial myxedema. Actually, this term is a misnomer. Why? Because the term myxedema used to be applied on hypothyroidism in the past, because there was, in hypothyroidism, there is deposition of myxomatous material or myxomatous tissue in the subcutaneous tissue all over the body, which causes the weight gain and the edema. Okay, but here, pretibial myxedema, this means this is seen in Graves' disease, hyperthyroidism, one of the important causes of hyperthyroidism. Why is it called like that? Because there is subperiosteal deposition, subcutaneous deposition of myxomatous material in the subcutaneous fat overlying the shin of the tibia. Hence, pretibial myxedema. Okay? But the cause is Graves' disease. Is it clear? Or did I confuse you? Okay. Now, the symptomatology of hyperthyroidism and the signs, they vary with age and with the underlying etiology. Of course, the eye signs, like I mentioned, the pretibial myxedema and thyroid acropathy occur only in Graves' disease. All right. And as I mentioned, pretibial myxedema is an infiltration on the shin, essentially occurring only with eye disease, meaning that if a Graves' disease patient doesn't have thyroid eye disease, you won't be able to detect pretibial myxedema. Okay, and the same applies also for thyroid acropathy, which is actually very rare, and it consists of clubbing with swollen fingers and subperiosteal new bone formation. All right, I will show you the pictures. In elderly, actually, a frequent presentation is with atrial fibrillation, other tachycardias, and or heart failure, often with few other signs. Right. So this is clubbing. This is a normal fingernail. Look at your own fingernails. The line BC intersects line BD, forming an angle at B. This is the angle at the nail bed, right? But in clubbing by definition means what? Who can tell me? What is clubbing? Huh? What is clubbing? Who can tell me?
Obliteration of the angle of the nail bed.
Yes, excellent. Obliteration of the angle at the nail bed. So here in this panel B, you see the line BD forms a straight line with line AB. Where is the angle? The angle, instead of being obtuse like that, it became 180 degrees. In other words, there is no angle. It's lost. Okay? Type. This is grade 1 clubbing. Loss of the angle at the nail bed. Grade 2 clubbing in addition to loss of the angle, there is also parrot beaking or increased convexity of the nail, like here. This is grade 2 clubbing, right? Grade 3 clubbing is seen on the right-hand side. This is called drumstick appearance. Why? Because in addition to loss of the angle, increased convexity of the nail, there is also enlargement of the terminal phalanx of the finger, looking like a drumstick. Okay? Grade 4 clubbing is exactly the same like grade 3, but in addition, there is broadening of the wrists and ankles due to subperiosteal deposition of new bone in these areas. And it's called pulmonary osteoarthropathy. Why? Because the grade 4 clubbing was first described with the pulmonary causes of clubbing. So we have seen the definition of clubbing, we have seen the grades of clubbing. Now, what about the causes of clubbing? Who can tell me what are the causes of clubbing? Causes of clubbing. We asked third-year students this question. Are you still there? Can you hear me?
interstitial lung disease كان في حاجات GIT.
Right. Let's, for the sake of completion and for the sake of organization, let's subdivide the causes of clubbing into systems. Yani pulmonary causes of clubbing, cardiac causes of clubbing, hepatic causes of clubbing, GIT causes of clubbing, endocrine causes of clubbing, and familial or idiopathic. So lung causes of clubbing. Interstitial fibrosis.
Carcinoma.
Yes, bronchogenic carcinoma and interstitial lung fibrosis. Bronchiectasis is very good. What else? The other suppurative lung diseases, mainly lung abscess and empyema. Don't forget those. And mesothelioma. This is a malignant tumor of the pleura. All right? Okay, these are the lung causes of clubbing. But what about the cardiac causes of clubbing? Who can tell me?
Cyanotic heart disease.
Yes.
Infective endocarditis.
Excellent. Congenital cyanotic heart disease and infective endocarditis. Very good. What are the hepatic causes of clubbing?
Primary biliary cirrhosis.
Excellent. Primary biliary cirrhosis. Yes, it can be also seen in some cases of autoimmune hepatitis, right? Okay, GIT causes of clubbing.
Cystic fibrosis.
Inflammatory bowel disease.
Inflammatory bowel disease, exactly. Ulcerative colitis and Crohn's disease, right? Yes, cystic fibrosis also can cause clubbing, but it is very rare. Yani. I have seen maybe 2 cases my whole life. Okay. Okay, what are the endocrine causes of clubbing? I just mentioned it. Yes, Graves' disease, thyroid acropathy. What else? In primary hyperparathyroidism, there may be pseudo clubbing or false clubbing, because there, I will tell you later on, next time, inshallah, there is resorption of the terminal phalanx. This will cause the fingers to appear as if there is clubbing in the fingernail, but actually there is no clubbing. Okay? And if you search for all these causes and you don't find any causes, then it is familial or idiopathic, right? Okay. Anything the problem?
No, doctor, it's clear.
Okay.
No.
Now, how to test for clubbing? How to test for clubbing? The very famous Shamroad sign or the window test. Yeah, you call it the window test. Like here, when you have when the angle at the nail bed is preserved and you ask the patient to put 2 adjacent fingernails together, like in the picture, you will find a rhomboid space in between. This is the window, okay? And the nails are close together. But if the patient has clubbing, there will be no window. In addition, if there is advanced clubbing, like here, the nail beds, I mean the nails, they are convex like that, parrot beak in appearance, and they are away from each other, right? Type. What else? You can look tangentially. You can compare your own finger to the patient's finger by putting your finger opposite to the patient's finger. And you compare your own angle with the patient's angle. All right? Okay? If the angle is there, like yours, so the patient doesn't have any clubbing. If there is no angle, this means that there is clubbing. All right? Another test that is neglected, or it's not very famous like the other tests I told you about, it's the phalangeal depth ratio. Phalangeal depth ratio. Normally, the interphalangeal depth, or the distance at the distal interphalangeal joint, is larger than the distance measured at the angle of the nail bed. But in clubbing, it's going to be reversed. The distance at the angle of the nail bed will be larger than the interphalangeal depth. All right, is it clear? But actually, the best test to elicit clubbing is by eliciting fluctuation. Okay, how is fluctuation elicited? I will show you in a minute in a video. All right. Actually, I have put those videos on Moodle for you to consult. I don't know if you have seen them or not. Did you see Moodle? Huh?
Yes.
Did you see how to test for fluctuation? Huh?
لا أنا شفت التست بتاعت الكاربل tunnel.
Okay. طيب. يعني so no need for me to show you the tests for carpal tunnel syndrome, right? Huh?
I've seen them.
طيب. Who is talking? Dr. Anagwa? Huh?
Hi, doctor.
Okay, so here is let me open the video and then I'm going to share it. 1 minute. It's opening. Okay, now tell me if you can see the video. How can I show it to you? Can you still see my slides? Huh?
Yes, بس مفيش فيديو.
Okay, Tab, let me share the video. 1 second. Here. Can you see the video now?
No.
Now, can you
No.
see it?
Yeah, it's now you
Okay,
can see it.
okay, let me explain to you. It's very brief. It's 3 seconds long. This is the finger of the patient. Can you see my cursor?
Yes.
Huh? This is the finger of the patient. Here, this is the left thumb of the doctor, the examining doctor, and the left index finger of the examining doctor. He is compressing at the area of the junction between the nail and the skin at the angle of the nail bed. And this is the right thumb of the examining physician, the right index finger of the examining physician. By doing fluctuation, he compresses on one side and feels the impulse with the other side, like here. Can you see it now? Does it move?
No, it's not working. Now it's moving.
It's moving.
Can you see it?
Yes.
Again. Okay?
Okay.
The doctor will you will feel a spongy sensation underneath your compressing finger. This means this is fluctuation, all right? So fluctuation actually is the best test to check for clubbing, okay? All right. Let me return to the slides again. Did the video disappear?
Yes.
Okay.
Yes.
Did the slides
Missing
appear?
slides.
Did the slides appear? Did they appear now?
Yes.
Yeah.
Done. In slideshow?
No.
Not yet. Now it's like
Yes.
Okay, great. طيب خلاص يبقى now we have seen the definition of clubbing. We have revised the definition of clubbing, the causes of the grades of clubbing, the causes of clubbing, and how to test for clubbing. Anything that is not clear? This is very basic knowledge, very basic skills that you need to know. But I'm just revising because I know that most of you have forgotten how to do all that. All right? Time. So this is thyroid acropathy. You see a patient with Graves' disease with eye signs, clubbing, and pretibial myxedema. Okay? Another patient with, you see, a moderate goiter in the neck, with exophthalmos, periorbital puffiness, with pretibial myxedema extending to the dorsum of the feet, and clubbing, thyroid acropathy again. Very evident. Okay, is it clear? Is it clear?
Yes.
All right. Now, thyroid function tests are mandatory in any patient with atrial fibrillation because in elderly we have what is called apathetic thyrotoxicosis. Some elderly patients, they present with a clinical picture which is more like hypothyroidism with very few signs, and so a high degree of clinical suspicion is essential. And if you do thyroid function tests in such elderly patients with apathetic thyrotoxicosis, you will find that they have hyperthyroidism, right? The other atypical presentation in children is that they frequently present with excessive height or excessive growth rate, opposite to what occurs in hypothyroidism, and they have behavioral problems like hyperactivity, and they are erroneously diagnosed as having ADHD, right? But in children, weight gain rather than weight loss is there. Why? Because they feel hungry all the time, so they eat high-calorie food containing items, potato chips, chocolate, and so on. So they tend to put on weight rather than lose weight. All right? Is it clear?
Yes.
Now, regarding goiter in hyperthyroidism, it can have different shapes. This is how goiter of toxic multinodular goiter looks like. You see, this is a middle-aged lady having a moderately to large-sized multinodular goiter in the neck with possible retrosternal extension. You see, it's bosselated. The surface is not smooth. It's bosselated. You can actually see different nodules. A nodule here, there, here, here, and there, right? She doesn't have any eye signs, right? Unlike the patients with Graves' disease that I have shown you. And this is the neck of a patient. We don't know if it's a male or a female, but most probably it's a female, relatively older than this lady because you can see the folds of aging in the neck. And she has a definitely large toxic multinodular goiter with retrosternal extension. Here you can see several nodules again. The surface is not smooth, it's bosselated. Here you can see a nodule here, there, another one here, here. And she has dilated veins. They are tortuous and elevated above the level of the skin, over the goiter and over the sternum as well, right? Is it audible? Is it visible to you?
Yes, doctor.
Okay. And this is how a solitary toxic nodule looks like. These are the necks of two young ladies. This is a Caucasian one. This is one from our part of the world. You see here there is no goiter, but here there is a single nodule in the isthmus. Again, this lady here on the right-hand side, most probably this lady has a dominant nodule. How do I know that? Because you see, she has a goiter. I mean, the whole neck is enlarged, not only this nodule, but inside the enlarged thyroid, there is a dominant nodule, because not all thyroid nodules are clinically palpable. There are some subclinical or subcentimetric nodules that can be visualized only by ultrasound. All right? Okay, so this is the trick to determine whether this is truly a solitary toxic nodule or it is a dominant nodule in a multinodular toxic goiter. All right, this is how to palpate the thyroid. All right, you stand behind the patient and you adjust the neck flexion by your thumbs and index fingers. And please watch the video that I have put on Moodle about examination of a thyroid swelling. Now coming to eye signs in Graves' disease, okay? We have less than a minute left, so I suggest that we leave this meeting and start a new meeting in order for not to miss the important eye signs, all right? So let's leave this meeting and join again, all right?